All right, I'd like to welcome you to week 4 of me going through the PowerPoints and hopefully shedding some light on some really important topics like uppers and all-arounders. So I hope you're having a good week, and we're going to move through some of the substance-related disorder material so that way we can have some more in-depth conversations on how to help our clients. So getting into some of what we were going to talk about today is the topic of uppers. Uppers are a class of substances that are the most widely used class of drug in all of the world. They're known to increase energy and alertness. They can be mild, moderate, or they can also provide an intense rush that has been described like no other. It also, use of uppers can cause severe health problems when abused, and can even lead to fatalities and death. Um, with uppers, it's really important to understand that there's a rapid increase of tolerance, and with that disruption in brain chemistry, there is a very, very high propensity for abuse and addiction, and this can be really challenging to work with clients. So there's various types of uppers. A lot of them we know about, like caffeine, nicotine, ADHD medications, diet pills, cocaine, amphetamines, ephedra, and then there's some that are more more widely known in other parts of the world, like betel nut or cat or cot or yoimbe. And a newer school of upper is called bath salts. And basically what's really hard about this topic is a lot of these things are white powder. Like most of these things are white powder. And so it can be really hard to know what you're getting. And that's one of the main risks associated with some of the use of these drugs is sometimes people think that they're getting crack or cocaine or methamphetamines or whatever, and it could be some sort of new school derivative of a substance. So it can get very, very confusing, and people really don't know sometimes what they're ingesting or taking. So in terms of uppers, this slide comes straight out of your book. Last year in the United States, 4.6 million Americans used coke. I think that number is probably higher. And a lot of people are smoking cigarettes still, even though the numbers are down. People are vaping more, and that's also causing huge problems in our society, and people are getting lung infections, and that can be fatal as well. Coffee and caffeine is one of the #1 used substances in the world, and a lot of people are still drinking soda or soft drinks. So these are just some facts straight out of your Inaba book. So with uppers, there's this concept of borrowed energy. So basically, we have natural energy existing in our bodies, thankfully, and we need this in order to move and live and be. What happens when people take uppers is that there's basically a dumping of neurotransmitters into the brain, as well as they block also this natural reabsorption and metabolism of energy chemicals. So there's a lot of these drugs within the areas that they collect in within the synaptic gaps, and that can be what causes the intense highs. And with that, since there's only so much of these neurotransmitters to go around, and just like in a factory, it needs to be reabsorbed, recreated, remetabolized. So there can be a significant crash or withdrawal, and that can include severe depression. And so that's something to really be mindful of when working with clients that might be using these drugs at higher levels. That people can get, some of these neurotransmitters do get depleted, and it takes a while for our body to naturally build those large amounts of energy back up, or to even get back into some sort of balance. So in terms of our reward control circuit survival pathway, part of our brain, all stimulants have some effect on this pathway. Normally, this is like our survival mechanism. It's our part of our brain that tells us when we're hungry, when we're thirsty, when we need, when we're feeling sexually stimulated. Some of the stronger stimulants artificially overstimulate this pathway and falsely signal the brain that these needs need to be satisfied. So a lot of times, with stimulants, one of the one of the side effects can be a lot of hyperarousal with sexual desire, and we'll talk about that later on. But just knowing that this pathway is completely overstimulated, and people actually forget that they're hungry, forget that they're thirsty, and are just very much in a state of hyperarousal. And basically, these strong stimulants can dump just 2 to 10 times as much as a dopamine, other neurotransmitters, just an exponential amount into our system, and this causes a lot of imbalance within our brain and the reward pathway. And sometimes when people are withdrawing from this is why some people have a hard time finding pleasure in pleasurable activities again, because these feel-good chemicals have been depleted, and it just takes a while, it just takes some time. Okay, so with uppers, tolerance just rises very, very rapidly with uppers. It basically also this is because downregulation occurs and there's a decreased number of serotonin and dopamine receptors in the brain. So basically, because there's such an influx in those synaptic gaps, the brain signals, oh, we don't need as many receptor sites, and so then they stop making as many receptor sites, and so then it downregulates to try to rebalance the brain, and that causes a huge chemical imbalance. A lot of times, there's also a very powerful psychological dependence. Again, like last week when we were talking about those dendrites that remember the psychological memory of an experience of a drug, that psychological memory is extremely potent and powerful, and that can cause a lot of the craving, and it can cause a lot of the need to fulfill the rituals associated with the drugs, the cycle of using, the addiction cycle of using that drug. There's also physical dependence, but it's not as powerful as, let's say, drugs like heroin. Sometimes people can even medically detox without even going to a hospital. Sometimes they just crash and they don't feel good for a couple of days. But in terms of the psychological dependence, it can be very, very hard to manage, and people really, really struggle with that, and that's where you'll see them in counseling. All right, so there's cocaine. Cocaine is one of the top uppers we're seeing around lately. It's rampant in Santa Barbara, that's for sure. It releases catecholamines like dopamine, epinephrine, and norepinephrine. It definitely increases confidence and stimulation, and people can also feel aggressive at times, and some physical features include increased heart rate and increased blood pressure. And again, just some of the top things to look out for is that it does cause a pretty large neurotransmitter depletion. It does cause a lot of exhaustion. It can cause paranoia, psychosis, dehydration, and uncontrolled heart rates. So this is a slide right out of your book. So some of the things that we just talked about, there's epinephrine, norepinephrine, dopamine. There's also some serotonin and some acetylcholine. So a lot of chemicals at once are getting moved around, shifted around, and it causes a lot of dysregulation in terms of our mood and our mental stability. So cocaine absorption, cocaine is typically absorbed in several different ways. Some people snort it through the nasal passage, some people orally rub it into their gums, some people smoke it, and some people actually use it intravenously. So you can see that this is the rates of absorption, the fastest route being the intravenous use, followed by smoking it, and then nasal through snorting it through our nasal passages, and then orally. So some of it definitely it matters. Rates of absorption matter depending on how people use it, and sometimes people do a combination of both, where someone might snort some and rub it into their gums. So it's important to know and to ask our clients, oh, how are you using this drug? What ways are you getting it into your body? Cocaine's been around for a really long time, as it mentions in your book, and And, you know, people used to chew the leaf. They used to chop it with ash and rub it in their gums. They used to drink it like tea, like a cocaine tea. Um, People also used to inject it and still continue to snort it, and also freebase it with by smoking it, and um, and they can freebase it or use the crack crystals. A lot of the cocaine that we're seeing here in California comes up through Mexico. A lot of our drugs come up through Mexico, and you might hear on the news of the Congo boats and stuff like that. So it's mainly based out of Mexico. So just know that that's kind of where the majority of it's coming up through. So a little bit about cocaine and its metabolites. It metabolizes pretty quickly, which is also what causes the increase in tolerance. It metabolizes in about 30 to 90 minutes, and that's why people typically want to use more and more and more and get more. Um, and it's not detectable in our urine after about 36 hours because it is water soluble. Um, in terms of sexual side effects, low use can enhance sexual desire, and people do consider it an aphrodisiac. High doses, though, can cause sexual dysfunction and high risk sexual behavior and unusual sexual practices. And so sometimes we do have to assess for that in clients in terms of, you know, if there's any trauma there, and if sometimes there can be also some sexual assault or regrettable sex associated with some substance use. And that's where we get a lot of that substance use and trauma um, that can be really intertwined. Cocaine is also linked to aggression and violence. It is it's also, people tend to mix it a lot with alcohol, and alcohol, when you add alcohol to cocaine, it becomes a new chemical compound called cocaethylene, and cocaethylene is a byproduct of mixing these two things. And cocaethylene can be very, very toxic, and it seems to increase chances of cardiovascular dangers like heart attack, and it also causes people to get violent and aggressive. I know that working out in Isla Vista for a long time, we saw that a lot of the times with college students, people that were mixing cocaine and alcohol and getting arrested for getting in fights and stuff. So it is, it's very, very potent, and just something that you need to be aware of. And additionally, emotionally, it overstimulates the brain so much that a lot of our functioning in the cortex, where we're responsible for, you know, decision making and impulse control, that's all compromised. So you get this overstimulation, this overconfidence, and this decrease of impulsivity, or increase in impulsivity. So it's a very risky combination. Some of the withdrawal effects can last months or even years, depending on how long people have been using cocaine, and at what frequency, and how much. So it all depends on the person, and so, but just know that the withdrawal effects, although the metabolites can be out of our urine, some of those withdrawal effects can continue. Some symptoms include anhedonia, anergia, emotional depression, a loss of motivation, insomnia, agitation, anxiety, and intense cravings. A typical cycle of compulsive cocaine use is that the user typically crashes and feels pretty bad and pretty sick and pretty flu-like, and a few days later begins to feel better and returns to a state of euthymia from dysthymia. And then a week or 10 days later starts to really feel some cravings, especially within that reward pathway as the downregulation occurs. And emotionally, they're feeling that decrease or that depletion in neurotransmitters, so that emotional depression can creep in. And then, 2 to 4 weeks after vowing to abstain, a lot of people, that craving and that the depression can begin to build, and can lead to relapse. So it's important to understand this, so that way when you're working with clients that have an affinity towards cocaine, you can help them to prevent these slips and relapses by getting to know their process and helping to do some relapse prevention and figuring out how they can manage their cravings, attend to their depression, and and that in itself can prevent those slips from occurring. Cocaine can trigger some paranoid psychosis and some stimulant-induced paranoid psychosis and schizophrenia. And this happens when people are using high rates of cocaine. Sometimes it can be difficult for clinicians to differentiate between a pre-existing psychosis and a cocaine-induced psychosis. So sometimes people need to, that's why it can be helpful sometimes to have somebody be hospitalized, so that way if it is a cocaine-induced psychosis, they can detox, and then those symptoms will disappear after a period of abstinence. But so it can be hard to tell sometimes if someone's not giving you the full truth, if somebody really is in a psychotic episode, or if maybe they're using a substance that can be causing that psychosis. And sometimes we see that in a severely mentally ill population. Another class of commonly abused uppers are amphetamines. Amphetamines are a class of powerful synthetic stimulants with effects similar to cocaine, but they last much longer and are somewhat cheaper to use. Amphetamines are usually snorted, injected, or taken orally, and there are several different types of amphetamines. Amphetamines, methamphetamines, dextroamphetamines, dextroisomer methamphetamines, or crystal meth. All of the effects are similar, and they're all white powder. Amphetamines in the brain. Amphetamines increase norepinephrine, epinephrine, and dopamine in 3 different ways. They force the release of these neurotransmitters in nerve terminals. The intake pumps reverse function and spit out extra neurotransmitters, and they block enzymes that metabolize the excess neurotransmitters. Prolonged amphetamine use in and of itself alters brain chemistry in a way that increases craving. This process also occurs with cocaine. So this is not just selected to, this is not just for methamphetamines. This occurs in several different uppers. Brains of meth users in one study show an average loss of 11.3% of their limbic gray matter, particularly the hippocampus areas associated with craving, emotions, mood, and memory. Users with a strong tendency to relapse have subdued activity in 5 different regions of the brain. So this implies that those with a tendency to relapse have impaired decision-making ability and find it hard to resist a craving. So just know that there are many different parts of the brain, 5 different brain regions that are affected, and that's why it can be so difficult to manage relapse. And that a lot of this, the best we can do right now in psychotherapy is through behavioral interventions. Amphetamines and mental emotional effects. These are a good list of what people can feel. There can be mild to intense euphoria, alertness, sexual impulsivity, a sense of well-being, confidence, irritability, paranoia, anxiety, aggression, mental confusion, poor judgment, impaired memory, and hallucinations. Another common amphetamine that it can be used and abused are diet pills. At any given time, I think these rates are a lot higher, but 24% of men and 38% of women in the United States are trying to lose weight. Presently, only 2% to 3% use diet pills. That is a statistic right out of your book, and I believe that those numbers are higher, but that's just me. In general, diet pills are only supposed to be used for a short amount of time. Another amphetamine that we're going to be talking about shortly that is also used for weight loss off-label is the ADHD medication. Working with clients, a lot of the times people will use those medications knowing that they do create a loss of appetite, and they will use them to help manage their weight and in an unhealthy way by either taking them when they don't need to be taking them, or even taking them and crushing them and snorting them, just all different kinds of things. So you might be wondering, what are some of the differences between cocaine and amphetamines? So usually cocaine is more expensive. Many users report that the rush or the high from cocaine is greater than that from amphetamines, but amphetamines release a greater amount of energy. So there's, I don't know, the jury's out on that. Duration or action, cocaine's major effects last about 40 minutes, and amphetamines can last from 4 to 6 hours. So that's way longer. Cocaine is plant derived, whereas amphetamines are synthetic. For cocaine, you can snort it, smoke it, and shoot it. Methamphetamines are typically smoked, snorted, and injected, but they can also be ingested. Addiction rate. Methamphetamine users seem to fall into addiction more quickly, whereas cocaine, and then and they also enter treatment sooner. So cocaine users tend to not, they tend to not fall into addiction as easily, and they tend to not seek out treatment as much as those who become addicted to methamphetamines. So, oops. Like I was saying, another upper is ADHD medications. ADHD stimulants include amphetamine stimulants like Adderall or Dexedrine or Vyvanse or Dextrostat. Other ones are methylphenidate stimulants like Ritalin or Concerta. Those might be some of the ones that you've heard a lot about. Non-stimulants are Strattera or Intuniv. And then some people use antidepressants like Wellbutrin. And then there's also blood pressure medications like clonidine or catapres. So there's a lot of different kinds of ADHD medications out there. There are also a lot of alternative therapies to taking medications, and so depending on people's philosophies and clients that you work with, other therapies can include dietary changes, education, exercise, lifestyle changes, behavior modification, psychotherapy, and parenting classes. Some research has shown that methylphenidate has alone worked just as well as methylphenidate and therapy for ADHD. So, you know, people are still kind of trying to figure out how to best support people with ADHD. And I think part of it is working with your client to figure out what their needs might be and what their goals are. And if they're wanting a referral for a medical evaluation, knowing how to appropriately refer. Some key notes about ADHD medications. There's several reports of psychosis or mania or hallucinations amongst patients treated with ADHD medications being reported by being received and reported to the FDA. The diversion of Ritalin and Adderall to non-medical use led to an increase of an abuse in the mid-2000s. I don't know if you guys remember that, but there was a pretty strong uptick. And that's common when I used to work with a psychiatrist, Dr. Feliciano, and he used to say that there's always going to be an uptick in medications as something gets newly prescribed, and that was the time when ADHD medications were really hot on the scene. So I think that things have calmed down a bit, but there definitely was an increase in abuse, and because of that, the medical community has taken steps on becoming more responsible and accountable on that front. Ritalin has a strong addictive liability. It's been sold on the street and it's used as a party drug. And also, U.S. military bars anyone who used Ritalin in adolescence from military service, which is, I think, a shame, and also it's just a shame. Other ADHD key findings. There are grave questions about the long-term effects of giving strong stimulants to children. These things haven't been around that long. There's a high occurrence of ADHD in drug abusers with an increased risk for substance abuse in adults with untreated ADHD. And one study shows that boys with ADHD who are treated with stimulants like Ritalin are 84% less likely to abuse drugs and alcohol when they are older compared to those who are not treated. Research indicates the need to treat ADHD patients with medications throughout their lives. So that was one study. Moving on to another upper or stimulant, there's the methamphetamines. They're usually a white, bitter tasting powder or pill. There's also crystals that look like glass fragments, which you can see in the top left corner. They can be colored like blue or white. Chemically, it's very similar to the amphetamine family. It can be administered in all of the same ways, inhaling, swallowing, snorting, or injecting. And methamphetamine does increase the amount of dopamine in the brain, which involves movement, motivation, and the reinforcement of that reward pathway. Long-term health effects can be extensive, including for those who are injecting, there's a risk of contracting HIV and hepatitis. So one of the harm reduction techniques used can be the clean needle exchange program, where people can get clean needles and reduce that harm of getting those diseases. There can also be some pretty severe dental problems. You've probably seen pictures on the media of so-called meth mouth. There can be intense itching and scratching, leading to sores on people's faces. There's also picking. People can like pick, and it's basically this need to do this repetition of a behavior. A lot of time, again, there's violent behavior because it's that increase of there's so much energy in the body, and there's not there's a decrease in the ability to regulate, and so there's a lot of impulsivity and violence. And there can be a ton of paranoia. People can overdose on methamphetamines, people can have strokes and heart attacks or organ problems. And basically, first responders try to treat the symptoms or the conditions. So if somebody's having a heart attack, they're going to try to, work on treating that symptom of the heart attack, and not necessarily the methamphetamine at that point. So something like that. When people stop taking it, the withdrawal symptoms can be really, really hard. They're pretty intense. The drug cravings can be intense. There can be psychosis, pretty severe depression that can even lead to feelings of wanting to take one's own life, and anxiety and a lot of fatigue. From again having that borrowed energy for so long, there's a fatigue and there's a depletion where people just crash. There's also synthetic methamphetamines and bath salts. This is done when people like chemists or entrepreneurial chemists can alter the cathinone molecule, which is the basis for bath salts or the whole series of methamphetamine-like drugs. Bath salts are also sold as plant food, jewelry, or glass cleaner, insect repellent, spot removers, ladybug attractants, and are not for human consumption to avoid any government restrictions. So you may see things that are labeled as such, and those are examples of how they get through the law and the federal regulations. The number of products in psychoactive active bath salts increases so quickly that the United States and the United Nations simply refer to these drugs as NPS, or new psychoactive substances, because basically by the time they get around to banning one, another one pops up in its place. So it's really, really hard to ban and control and try to restrict. There are plant stimulants as well. There's one called cot, which I remember one student bringing up earlier during our brainstorm. Cot is known as it's a water bush driving the economic force in Somalia. The main psychoactive ingredient is cathinone. It has a half-life of about 90 minutes. People usually take these dry leaves and twigs and crush them and make them into tea or paste. And now it's being smuggled into the US, and even though it's banned, people are still using it, so it's out there. There's also betel nuts, and this dates back to the 23rd century. It's been widely used in India, Pakistan, and the Arab world, Taiwan, Malaysia, the Philippines, New Guinea, Polynesia, southern China, and some countries in Africa. Today, anywhere from 200 to 400 million to 450 to 600 million people worldwide use betel nuts, not only as a recreational drug, but as a medication. Basically, it's similar to that of nicotine or coffee, and it creates a mild euphoria. It excites the body, and it decreases fatigue. Then there's yoimbe, and it's a bitter, spicy extract from Africa, from an Africa tree. It can be brewed into a stimulating tea or used as medicine. It's reported to be a mild aphrodisiac. It's also it's found in the bark, and it can be extracted and formulated in either tablets or tincture for oral ingestion. It's been known to create a mild euphoria and occasional hallucinations, and it can cause death if taken in large doses, because it causes respiratory paralysis. Then there's ephedra. This is a mild to moderate stimulant used medicinally to treat asthma, narcolepsy, allergies, and low blood pressure. The extract of the ephedra has been used by athletes for energy boosts, and overuse can cause heart and blood vessel problems. Ephedra is also sold as an herbal stimulant in a wide variety of tablets and capsules. It was considered illegal or it was made a Schedule III drug in 2004, and it's unavailable now as an over-the-counter drug. And then there's caffeine, our most favorite drug in the world. It's the most popular stimulant. It's found in coffee, tea, chocolate, soft drinks, energy drinks, 60 different plants, hundreds of over-the-counter and prescription medications. Caffeine is an alkaloid of the chemical class of the xanthines. Its half-life in the body is about 37 hours, so it takes 1,535 hours for 95% of the caffeine to be excreted. So it takes a while to detox from caffeine. 20% of US adults consume more than 350 milligrams of caffeine per day, and 3% consume more than 650 milligrams daily. Here is a list of different various caffeinated drinks and medications, and you can see how some things have more than others. A no-dose pill tablet has like 200, whereas brewed coffee has 135. You know, there's all different kinds. 80 for dextrim, which was I think a diet pill, and then there's Red Bull. There's all different kinds. Caffeine has a lot of uses. It can be a bronchodilator in asthma patients as an adjunct to pain medication and to counteract a sudden drop in blood pressure. It's a decongestant. It's a diuretic. It's an alertness aid. It's an appetite suppressant. It's an analgesic to control menstrual pain, and it's a treatment for headaches and especially migraines. Non-medically, it can be used to increase alertness, dissipate drowsiness, and facilitate thinking. It does release stimulants, but it also inhibits adenosine. Withdrawal symptoms do appear within 12 to 24 hours, and people typically have a headache, feel very lethargic, depressed, not alert at all. They may have trouble sleeping and feel some irritability. Tobacco is another upper. For some of the reasons people continue to smoke. You know, I'm not going to go into a ton of tobacco things just because I think we all know a lot about tobacco, but you know, some of the reasons why people continue to smoke is that socially there's a ritual aspect of lighting up. It can be associated with good times. It can be a way to manipulate mood or to be rebellious. Some people think that it helps to decrease their anxiety or give them a sense of peace. People sometimes think that they feel sexually attractive when they do it. Some people crave it physically because of the nicotine. Some people use it for weight loss, and people can self-medicate with tobacco, especially those with major depression. So there's a lot of different reasons why people choose to smoke, and many people know that they need to quit. That's not that they don't know it, but there's something that's going on there that's that, you know, nicotine has a very strong pull. So that we'll be getting into next week a little bit about motivational interviewing and how we can help people identify motivation to decrease or abstain from these kinds of things. Tobacco can also contain 4,000 to almost 5,000 chemicals. 400 are toxins, 69 are known cancer-causing substances. And cigarette smoke consists of fine particles of tar and nitrosamines. So those can also get in our clothes, our walls, and it's why pediatricians ask during screenings if parents smoke in the house, because a lot of times children can develop asthma. Withdrawal after prolonged use, it can cause headaches, nervousness, fatigue, hunger, severe irritability, poor concentration, depression, increased appetite, sleep disturbances, and intense nicotine craving. So basically the withdrawal effects are always going to be the opposite of the drug. Vaping, we've seen an increase in vaping over the past few years. Vaping is when people use e-cigarettes. They're devices that operate by you heat a liquid solution to a high enough temperature so it produces an aerosol that is inhaled. A lot of them have been flavored and have cute little names, and like, you know, they taste like donuts and stuff like that. Young people who use e-cigarettes are 4 times more likely to start smoking cigarettes. And there's also been an outbreak of lung injuries associated with vaping that you've probably seen on the news, and you can get more information if you'd like through the CDC. There is tobacco medication assisted treatment for tobacco cessation or for smoking cessation. The most popular being Chantix. It's a medication that controls craving. There's also Zyban. They've been shown to have initial success rates of about 44 and 30.5% respectively, along with counseling. Other medical treatment approaches can consist of nicotine replacement products or NRTs. NRTs can look like patches, gums, inhalers, nasal sprays, and lozenges. And those can be very helpful for people that are trying to quit. So moving on, we're going to talk a little bit about all-arounders. All-arounders is a huge topic. I wish we could spend like freaking 8 weeks talking about just all-arounders because it's super fun. Unfortunately, we have a lot to get through in this class, so we're going to spend just a short amount of time on reviewing some of these things. So all-arounders are things that have hallucinogenic type properties. They're things that may take you up, down, and all around. Some examples are LSD, salvia, DMT, DXM, peyote mushrooms, ecstasy, things like that. There's a lot of positive reasons why people use them. There's a lot of negative reasons why people use them. So we're going to get into some of those right now. There are five main chemical classifications of psychedelics. There's the indoles, which is like LSD, psilocybin mushrooms, and ayahuasca. There's the phenylalkylamines, like peyote, MDMA, or ecstasy. There's the anticholinergics, and those are things like belladonna or datura. There's individually classified all-rounder psychedelics. Those are like ketamine, PCP, salvia, or DXM or dextromethorphan. And then there's cannabinoids, which are found in marijuana. So actually, cannabis is considered a psychostimulant because it has both hallucinogenic and stimulating properties. All psychedelics can cause an intensified sensation generalized by illusions, delusions, and hallucinations. Many of the psychedelics also cause stimulation, impaired judgment, and faulty reasoning. Historically, psychedelics have been used for thousands of years for religious, social, ceremonial, and medical purposes. They originally came from some of the 4,000 plants that have psychoactive effects. More recently, many psychedelics have been synthesized, like 2CB or the 2Cs, MDMA, and hundreds of other psychostimulants created every day by street chemists. Marijuana is obviously the most widely used psychedelic in the US. So in terms of assessing the effects, much of the information about effects of psychedelics is anecdotal rather than the result of extended scientific testing. So most plant-based psychedelics contain more than one active ingredient. Besides the toxicity of the psychedelic and the amount used, effects can depend on the emotional makeup of the user. So that's something that you can definitely do some psychoeducation around. If somebody's in the middle of a huge life crisis, it might not be the best time to be trying an all-arounder. People, also may not necessarily, they may be a highly anxious person by nature or fearful. So it's important to look at the emotional makeup of the user. The user's mood and mental state when using. So at that time, it's important to see what's going on for them and if they're ready for this, and to be able to make sure they're in a good frame of mind before going into something like this. The surroundings in which someone uses a drug is important, and that's something people can plan for, and that can be a really helpful tool in creating a successful experience. Experience with the drug can also matter. If somebody's had good experiences and they have a positive correlation with it, it's going to make a huge difference. Whereas if somebody's had a bad trip, they may be fearful going in that they're going to have another one. So experiences with the drugs can also have an effect. And any type of pre-existing mental illnesses, this is this, if people are experiencing significant mental illness, this is not something that should be recommended in general. There are definitely research studies going on where people are using various hallucinogens to work with things like trauma or PTSD or treatment-resistant depression, but that's under the care of a doctor. And so I really try to dissuade clients from experimenting with their mental health when they're already not feeling very good by themselves. These all help determine the duration, intensity of the effects. So some physical mental effects, LSD, ecstasy, and most other hallucinogens stimulate the sympathetic nervous system, raising pulse rate, blood pressure, causing sweating, nausea, and psychedelics effect on the serotonin, alter sensory perception. This may even cause permanent changes in one's personality. I have seen this before, where someone will do one of these substances, and there are some permanent changes that were in fact made. The stimulation of the brainstem can overload the sensory pathways, making users acutely aware of all sensations. Disruption of the visual and auditory centers can confuse perception. An auditory stimulation, such as music, may jump to a visual pathway, causing the music to be seen. This crossover or mixing of the senses is known as synesthesia. All-rounders like psychedelics are known to induce these delusions. So there's these mistaken beliefs and illusions, mistaken perceptions, and hallucinations, sensory experiences without external stimuli, as well as synesthesia. So this could be like being able to taste the air, or being able to touch sound, things like that. Those are examples. Indole psychedelics like LSD, mushrooms, and ayahuasca are known as serotonin-like psychedelics because they seem to exert many of their effects through interactions with serotonin receptors, particularly those designated to the 5-HT2A. Besides affecting mood, sleep, and anxiety, serotonin influences areas of the brain that are most likely involved in generating hallucinations and illusions. So now let's talk a little bit about acid or LSD. Some of the mental effects of LSD is that it overloads the brainstem and sends the sensory switchboard for the mind. It causes sensory dreaminess, depersonalization, altered mood, impaired concentration, and weakened motivation. Illusions and delusions are also prominent with its use. One of the greatest dangers of LSD use is impaired reasoning and loss of judgment. So sometimes people will do things like try to drive, and that can be a recipe, obviously, for disaster. Another mental effect that can be not so great is bad trips. Basically, this is when people have acute anxiety reactions, and this is because acid or LSD affects the emotional center of the brain and distorts realities. And some users, and particularly the first time people use something, people can feel a little bit uneasy and a little bit nervous and scared and panicky, or they could feel very, very, very euphoric, or a little bit of both. It just depends on the person. And again, those 5 things that we talked about before, and the environment and the mental state and what's going on for them at that moment. Depersonalization and lack of a stable environment can trigger an acute anxiety, paranoia, or fear over loss of control and delusions of persecution. So again, just things to keep in mind. In terms of acid and mental illness, proponents of psychotherapeutic use claim that drug-stimulating insights can afford some users a shortcut through psychotherapy. We're going to be talking a little bit more about this, and I did add a bunch of resources into the Sakai site, basically where they do some LSD assisted treatment with psychotherapy, where therapists help the client uncover traumas and conflicts within the subconscious and help that patient heal. LSD users with pre-existing mental illness or instability can aggravate those conditions. So, and acid can cause more severe mental disturbances. So, not everybody is a good candidate for LSD psychotherapy or LSD assisted treatment, because some people do, especially with severe mental illness, it can cause more severe mental disturbances. And some otherwise normal users can be thrown into a temporary or prolonged psychotic reaction or severe depression that requires extended treatment. So this is one of those drugs where you kind of never know, you're taking a risk. And some people, it depends on the person, but some people, feel very strongly that acid has been a very important part of their life and their personal growth. And other people feel that it's not, that it's been damaging. So, there's a lot of research out there, and part of our job is to help our clients sift through what's right for them. So another thing to talk about is flashbacks and what's called HPPD. HPPD is called hallucinogen persisting perception disorder. Most flashbacks are provoked by some sort of sensory stimulus like sight, sound, odor, or touch. The other type of the other thing to consider is HPPD. It's a long-term, intermittent, or continuous experience of LSD-like visual and perceptual disturbances that can occur on a chronic basis. So this is something that can resolve or maybe persistent indefinitely. When working at UCSB, I did have a few students over my almost decade of working there that did get diagnosed with HPPD and did have some continuous experience of visual and perceptual disturbances. So this does happen, and it is a risk and something to definitely give some psychoeducation around if you're seeing clients. A number of psychedelics have the capacity to cause HPPD. LSD, MDMA, MDA, mescaline, DMT, PCP, marijuana, and psilocybin have been listed in our book as examples. Flashbacks are experienced by 23 to 64% of regular LSD users. And people have tried to treat HPPD, but it's been with limited success. So again, they're just trying to treat the symptoms like the anxiety and stuff like that, but a lot of the visual and perceptual disturbances continue. Moving on to another drug. This is a slide on mushrooms or psilocybin. Shamans have been using mushrooms to induce visions that would help treat illnesses, solve problems, or contact the spirit world. People have been using this for a long, long time. Psilocybin and psilocin are found in about 100 different types of species of mushrooms. The chemical structure of psilocybin is similar to that of LSD. Both wild and cultivated mushrooms vary greatly in strength. So a single potent mushroom might have the same as much psilocybin as 10 weak ones. So it's kind of hard to tell what you're going to get. So you could have one mushroom and it could be super strong, or you could have 10 and it could be really weak. So it can really vary. The psychic effects are obtained from doses of 10 to 60 milligrams and generally last 3 to 6 hours. The effects of mushrooms tend to include visceral sensations, changes in sight, hearing, taste, and touch, and altered states of consciousness. Typically, what happens is people will ingest the mushrooms and they will cause nausea or other physical symptoms before the psychedelic effects take over. There's typically less association and panic with mushrooms than with LSD. A major risk in shroom harvesting is mistaking poisonous mushrooms for those containing psilocybin. So that would be a real rookie move if somebody were to give somebody some poisonous mushrooms instead of the psilocybin mushrooms. There are other indole psychedelics. There's ibogaine. This is something produced by the African shrub, the African tabernacle iboga shrub, and some other plants. Ibogaine in low doses acts as a stimulant. In higher doses, it produces long-acting psychedelic effects and self-determined catatonic reaction that can be maintained for up to 2 days. And currently, there's research being done on the use of this drug to treat heroin, alcohol, and cocaine addiction. It's being researched by MAPS, which we're going to be talking about in a few minutes. There's also morning glory seeds. Seeds from morning glory plants or Hawaiian baby wood rose contain several LSD-like substances, particularly lysergic acid amide, which is 1/10 as potent as LSD. Because several hundred seeds may be ingested to get high, the drug can make you pretty nauseous. Morning glory seeds are sold commercially, but to prevent misuse, many are dipped in a toxin that it induces vomiting. There's also DMT. DMT is found naturally in South American trees like vines and shrubs and mushrooms. It's synthesized by street chemists as well. It's a psychedelic substance similar to structure to psilocybin. It can also be snorted or injected. It is it's pretty commonly used. South American tribes have been using it for at least 400 years. We see more of the synthesized stuff here in America. DMT causes intoxication, intense visual rather than auditory hallucinations, and often a loss of awareness of surrounding. It can last 10 to 60 minutes or less, so it's got a pretty short duration, considering that other psychedelics can last hours. There's ayahuasca. I'm sure this has been something that's been talked about more and more lately. It's kind of, there's a rise in popularity. It's a psychedelic drink made from the leaves and bark and vines of the Amazon jungle vines. Drinking this preparation causes intense vomiting, diarrhea, you get really, really sick, and then you get you enter a dreamlike condition that can last for up to 10 hours. So it's really quite the journey. The active ingredient is the indole alkaloid harmaline, and native cultures often mix yage with DMT plant extracts to intensify the effects. So people will mix the ayahuasca with DMT. Over the past few years, cults using ayahuasca as the focus of their beliefs have sprung up in Brazil. And in 2009, the federal court permitted the use of ayahuasca by a church in Oregon. So it's becoming more mainstream, and a lot of people are also looking into ayahuasca as a form of healing, especially from deep traumas. Another indole psychedelic is Foxy and AMT. There are two psychedelic tryptamines appeared in the 2000s. They also create hallucinations and euphoria, empathy, visual and auditory disturbances, and the effects can last 12 to 24 hours, whereas smaller doses can last 3 to 6. And then there's another class of psychedelics that is chemically related to adrenaline and amphetamines, although many have, the effects are quite different. They're called the phenylethylamines. I can never say that right. Phenylalkylamines, there, I said it right. And they take several hours to reach their peak. The first one being peyote. Peyote is a cactus flower or bud, and they're gray-green crowns of the peyote cactus that are usually cut at ground level, uprooted, and they're used fresh or dried. They contain mescaline and approximately last about 12 hours, and they're very similar to LSD. And there's way more colorful visions and hallucinations. Hallucinations being the most common with use of mescaline. Usually peyote is used in ceremonies, and it can consist of, especially with the Native American rituals, they ingest the peyote buttons and then sing and drum and chant hymns, and a lot of people seek that spiritual experience through psychedelic visions. And so it's really, really commonly connected to spiritual matters, and people don't tend to abuse peyote as much. Then there's MDMA. MDMA is a psychostimulant. It's the shorter name for 3,4-methyl diacetyl-methamphetamine. It's shorter acting than MDA, which is MDA is 10 to 12 hours, where MDMA is 4 to 6 hours. It can be swallowed or snorted or injected, much like methamphetamines, and it's usually sold as a capsule, tablet, or powder. So people think like, oh, it's Molly and that means it's pure, but nobody knows because it all looks like white powder or pressed powder. MDMA is typically taken at parties, raves, clubs, bars. Users claims that it creates a strong desire to move about, dance, and interact with other people. MDMA has a stimulant effect similar to amphetamines. It also consists of a tightness in muscles, which with some muscle spasms, people tend to also grind their jaws. So people might chew gum when they're using MDMA. People also clench their teeth, and that happens before some of the more psychic effects appear. Occasional users tend to have, with low, moderate amounts, are, most of the physical effects are pretty benign. People that use a lot of MDMA or have high doses can have pretty serious effects, including dehydration, blurred vision, headaches, agitation, nausea, anorexia, dangerous heart rhythms, and in a few cases, seizure activities, stroke, cardiovascular failure, coma, and high body temperature called hyperthermia. So what typically happens is people ingest the MDMA in about 3 to 4 hours, and then it takes about an hour for it to work, and then they feel the effects for about 3 to 4 hours. For the first few hours of use, basically it really dumps a lot of neurotransmitters into our system, and because of that, it again causes that down regulation. And so following an ecstasy experience, people can feel pretty extremely depressed because the serotonin gets dumped into our systems, and then our brains compensate by down regulating, and then we really have less dopamine and serotonin into this one's serotonin into our brains. And so it's important to check in with people if they're going to be using this, and make sure that they have a good plan for self-care, and making sure that they know where to go if they start to feel suicidal or depressed. Sometimes people mix MDMA with other drugs. There are polydrug combinations that are popular, one being acid with ecstasy, and then there's also it's not listed on here, but there's also mushrooms with ecstasy. There's hippie flipping and candy flipping. And then there's also Oxycontin, heroin, or GHB with ecstasy. There's also nitrous oxide with ecstasy, and then people will take MDMA with Viagra. So, and then people tend to drink as well with ecstasy. So it's important to talk to clients about mixing and how we can reduce the harm by doing just one, or talking to them about what they're trying to achieve when combining some of these drugs. Other types of phenylalkylamines, there's 2-CT or 2-CT2. So there's lots of different 2Cs. There's 2CB, there's 2TC7, there's all these 2Cs. So those are all examples of derivatives. There's N-bomb, which 25C N-bomb is very similar to it's a very toxic drug. It's caused some death in our community, because basically it looks like white powder, and people think that they're sometimes doing cocaine, but really it's pretty potent, and people will hallucinate and get pretty scared, and it can cause a wide range of effects within our bodies, and can cause our organs to react in a very negative way. So this drug can be very, very dangerous and risky, and that's just what I've seen of it with clients. Let's see. There's also STP. You might have remembered the popular band Stone Temple Pilots back in the day. STP is similar to MDA. It causes a 12-hour intoxication characterized by intense stimulation and several mild psychedelic reactions. It was really popular in the 1960s and 70s, but it's rarely seen today because a lot of people had a lot of bad trips on it. Then there's PCP. PCP was originally used as a dissociative and a general anesthetic for humans. And then it got, it's often misrepresented as THC, mescaline, MDMA, or psilocybin. It's another white powder. So sometimes it's hard to know what you're getting. It can be smoked, snorted, swallowed, or injected. It blocks sensory messages being sent to the central nervous system, and it dissolves inhibitions, deadening pain and resulting from the same mind-body separation caused by ketamine. Most of the problematic effects of PCP come from self-inflicted injuries and violent run-ins with authorities. PCP causes some pretty significant dissociative effects, which deaden the pain, and so people don't realize that they're damaging their muscles and body by overstressing it, and so that's pretty scary. Then there's ketamine. Ketamine is another all-arounder. It's a dissociative and general anesthetic used in humans, and people also use it with animals. It's used in a lot of veterinary procedures. Ketamine was the most used anesthetic in the Vietnam War. It also is currently being researched and as a form of treatment for trauma, and it's being used right now for treatment-resistant depression. So it's called S-ketamine. And some researchers are also are studying it to treat alcoholism in a technique known as ketamine-assisted psychotherapy. We'll talk more about that. Salvia is a plant whose unique psychic effects have been likened to taking a combination of various psychedelic drugs. It's basically, a lot of college students try it, maybe once, and then they're done with it. Basically, people chew it or brew it into a tea and then have a very brief hallucination, and then they're better within about 30 minutes. Then there's dextromethorphan that can be found in Robitussin. It's an opiate. It also it's in cough suppressants, and it's known as DXM or Robo. And basically, people can OD on this. And in that case, naloxone has been used to treat some of those overdoses. But it can cause euphoria, mild body separation, auditory and visual hallucinations, and a loss of coordination. So a lot of times adolescents and high school students might try to do this. We're going to be talking a little bit more in depth about microdosing. Basically, microdosing is when people take a hallucinogen and it's at a very small dose, so 1/100th of the expected pharmacological dose provided. And studies using such a microdose, it's called microdosing studies. And basically, it's growing in popularity, and people are using it to treat anxiety, depression, trauma, PTSD, and it showed a lot of great potential. And again, there's stuff posted on the website or on our site this week, so you can begin to look at some of the research behind microdosing. And I did post a couple of videos as well. Specifically, there's an organization called the Multidisciplinary Association for Psychedelic Studies. It's called MAPS. And the FDA is approving MAPS to do MDMA-assisted psychotherapy for the study of PTSD treatment. They also are researching LSD-assisted psychotherapy, ayahuasca treatment, medical marijuana and PTSD, ibogaine-assisted treatment, and more. And they have a very comprehensive website, so I do encourage you to check that out. The last thing we're going to talk about today is marijuana. Marijuana is going to come up, I think, clinically a lot for us moving forward now that it's considered legal and medicinal. Marijuana is considered a psychostimulant. THC is what contains the hallucinogenic property. The cannabis sativa tends to have more stimulating effects. Cannabis indicas tend to have more drowsy-like effects, yet everybody's really different, and so it just depends on the person. Cannabinoid receptors are abundant in parts of the brain, the lungs, the liver, and the kidneys, and it can regulate, especially in the brain, the learning, memory, judgment, and pleasure. Marijuana can be different when it's eaten, so that's another big harm reduction piece. Is sometimes people don't realize that, when people eat marijuana, it takes a little bit longer and it will peak more slowly, and so the onset and primary effects may last longer, and it can take like hours for it to begin in the first place. So a lot of times I will instruct people, you know, or give people some feedback on, you know, making sure that they take little bits at a time if they're learning their own levels of their own thresholds with edibles. As you know, marijuana is not what it used to be. In the 1970s, people used to just, you know, smoke a joint and that would be it. Now there's all kinds of things. There's dispensaries that look like Starbucks, and there's titrates and ice cream and I mean everything you can imagine, lotions, and you can eat it, you can smoke it, you can vape it, you can, I mean, it's incredible. There's so much advancement. So with marijuana, another thing to be mindful of is a concept called dabbing. Dabbing is something that I've seen some higher risky use with. It can be more abusive in nature. Basically, people take wax, marijuana, or THC wax, or just concentrates, basically, of it's a THC concentrate, and they will vaporize it within some hash oil or on a hot surface and inhale the vapors. And basically, it's very, 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 very potent. And the method is also very dangerous, and it can be explosive. And the THC content is very high. It's typically between 40 and 90%. And it can strongly affect the user for many hours to the point where it's uncomfortable and causes a lot of discomfort. There's a lot of synthetic marijuana as well. There's several medications now on scene to help with things like glaucoma or cancer, multiple sclerosis. There's Marinol, Sesimet, and Sativex. So there's 3 different kinds currently, and I'm sure there'll be more to come. There's also synthetic cannabinoids. Most of these are synthetic cannabinoid-like chemicals sold over the internet in head shops or as incense or herbal smoking blends. They offer a variety of trade names like K2, Spice Gold, Yucatan Fire, and they come in these little packets. Basically, it's just plant matter with a bunch of chemicals sprayed on it. These compounds do not test positive for marijuana, so they become popular in various countries. But because it is just chemicals, it can be dangerous and risky. Within marijuana, researchers have discovered more than 420 chemicals in a single cannabis plant. At least 30 of these chemicals, called cannabinoids, have been studied for their psychoactive effects when smoked or ingested. These are potent psychoactive chemicals, and they are converted by the liver and into more than 60 other metabolites. THC is the most potent psychoactive chemical, followed by cannabinol and cannabidiol, and they are the 2 other prominent cannabinoids. But they don't cause any psychoactive properties. They don't cause any type of high. So we've got these cannabinoid receptors. They figured out about in 1988, 1990 that we have receptor sites for that are reactive to THC. And then they figured out the discovery of anandamide, and which is an endocannabinoid. And so basically, we have these receptor sites, and they're all over the place, and they're mostly in the brain area, and they regulate the integration of sensory experiences with the emotions, and they also control learning, memory, a sense of novelty, motor coordination, and some automatic bodily functions. Some long-term effects of marijuana that, you know, people don't tend to like very much are what respiratory problems, especially for people who are smoking. Hyperemesis, I've seen this a lot in clients, where people have too much high potency cannabis, and then they have an episode with a vomiting syndrome, and this is called cannabis hyperemesis syndrome. So that's when you can't control your vomiting, and they try to give them things like Zofran to try to help people stop being sick. And it is under-recognized, but people do get really, really sick from having too much marijuana or cannabis. Um, there are some withdrawal effects to marijuana. Basically, it's the opposite of the drug for that person. So it can include anger, irritability, anxiety, aggression, aches, pains, chills, slight tremors, depression, sleep disturbances, inability to concentrate, decreased appetite, stomach pain, and craving. So we now have this thing called medical marijuana. And so people always ask me, what are some of the medical conditions that are associated with medical marijuana? And so here's a list of them. Um, there's things like anorexia, cancer, chronic pain, glaucoma, migraines. But basically, if you scroll down, it can be, a lot of different things. I think part of it is, we're still learning a lot about marijuana and how it can be really helpful for some people, and yet it can still be really hurtful for some people. So sometimes we've got to take some time to tease that out with our clients. How is it helping and how is it not helping? How is it hurting your life? How is it not? So we got to really kind of tease that stuff out. Some concerns that I've seen in my practice is just a general lethargy or apathy, giving up on important goals, increased anxiety or depression, difficulty emotionally regulating. Um, it becomes one's really only way to cope, relax, almost like an identity, if you will. There's a lot of missed opportunities and other ways to develop living one's life or enjoying one's time, and failed attempts to abstain, and having trouble regulating their use. Marijuana, although, a lot of things are addictive, and marijuana is definitely one of those things that people can have a pretty strong psychological addiction to as well. There's an assessment called the QDIT. It's very similar to what's called the audit, which we use for alcohol use disorders. But this is the cannabis use disorder identification test. It's also listed in the Sakai site, but it's something that you can use. It's a 8-question questionnaire that people can self-administer and learn more about their own relationship with cannabis. So for now, I think I'm going to stop talking, but this was a review of my slides for this week, and I hope that if you do have any questions, please write them down and let's discuss them during our next live meeting. All right, take care, everybody.